Well, good afternoon or good morning, as the case may be, wherever you are, and welcome to the 16th CVMA Veterinary Town Hall Series on navigating through COVID-19. I'm Louis Qantas, the president of the CVMA, and honored to introduce today's webinar. This Town Hall Series began in early 2020 when COVID-19 rampaged onto the world scene and started to exert its diabolical influence on all aspects of our life in Canada, and particularly for us, for the practice of veterinary medicine in all its various facets. Our last town hall was in the spring of this year, and back then, which one of us would have thought that COVID-19 would still be a significant factor into late 2021 and 2022. Our town hall series now runs on an ad hoc basis, but with all the changes happening, we felt it was time for another one. Because whereas the virus has mutated into variants, so have our concerns mutated. How should we best deal with what we are facing now? We're dealing not only with the animal side of provision of veterinary services, but also with the human side, particularly issues related to staffing and human vaccination requirements and business and legal concerns. Just share my screen here. There we go. Oops. So the CVMA is fortunate to have been able to provide expert information and advice to veterinarians in Canada, and we are grateful to have two such experts on today's town hall meeting on vaccine protocols and vaccine in practice settings. Our host today is Dr. Scott Weiss, who's very familiar to many of us from previous town halls, as well as from his Worms and Germs blog. He also is the recipient of the first ever CVMA Outstanding Achievement Award, presented by the CVMA at our convention just a few months ago in recognition of his outstanding service to our Canadian veterinary profession. He is a veterinary internist and microbiologist, a diplomat of the American College of Veterinary Internal Medicine, professor at OVC, and a zoonotic disease public health microbiologist at the U of G Center for Public Health and Zoonosis. He's also the chief of infection control at OVC Teaching Hospital and holds a Canada Research Chair in zoonotic diseases. Along with Dr. Weiss today, we are happy to have a special guest speaker, one who is also quite well known in the Canadian veterinary community. It's Mr. Doug Jack, who has been providing dedicated legal services to veterinary professions, to the professionals on a host of topics, including business and law, to risk management, to complaints, and even estate management planning. Mr. Jack has agreed to join us today to give us information and guidance related to staff and vaccine requirements, along with other advice considering the current state of vaccination, testing, government regulation, and legal precedents. Well, that's enough for me, other than to say that once the presentation is complete, we should have time for our speakers to take your questions. But I ask you to type any questions you have into the chat field at any time during the presentations, please. Please do keep yourselves muted and the video off to allow for best online experience. And yes, this meeting is being recorded. So with thanks to both our speakers today for your expertise and assistance, I would like to now turn it over to Doug to take it from here, please.
Dr. Qantas, thank you very much. It's my pleasure to participate in this town hall series. It's at least a couple of town halls that I participated in at the invitation of Dr. Weiss. And I'm pleased to be able to come today and share some information about essentially risk management practices within the clinic as it relates to the vaccination process. Without attempting to pour cold water on anything, I have to warn you that while it's everyone's expectation that this session will be informative and helpful, there may not be any definitive pieces of advice that you can take away. The law is evolving very quickly on these issues. The protocols are changing. It is typically done on a jurisdiction to jurisdiction basis, such that my comments today are intended to be at a very general level, at a very high level. And that's not because I'm attempting to dodge any of the issues, but rather that in truth, a lot of the regulatory aspects of the topics I'm going to bring to you today are governed on a provincial basis, and they change from one jurisdiction to another. I think you can safely accept that my comments at the high level will generally be applicable, but I think that, and I would urge you that if you plan on implementing the thoughts and recommendations that I'm going to make today, you should check with your own internal legal counsel to ensure that they are applicable and appropriate in your own jurisdiction. I plan on addressing 3 issues today. First, a commentary on the notion of mandatory vaccination policies within the clinic. Second, the development and implementation of a vaccination policy. Third, some general comments on screening protocols and rapid antigen testing. And if we have sufficient time, I'll speak on some interesting but probably less relevant issues as they relate to the practice of veterinary medicine. And that are the issues arising from working remotely. If we have time, and I'm sure we'll have a bit of time, we'll field your questions. And as you've been invited, make good use of the chat room, which Dr. Weiss is going to be monitoring for me, and will break in with any relevant questions at the time. At the outset, I want to acknowledge with thanks the assistance rendered to me by my partner, Danny Kaufo at BLG Montreal and Alexander Buswell at McCarthy Tetro in Montreal. They presented a similar program for employers generally recently, and I've benefited greatly from their comments. So with those prefacing remarks, let's move into the first section of my comments today, and that relates to mandatory vaccination policies within the clinic. Let me summarize the recommendation, and then we'll retreat and I will tell you how I got to that recommendation. And it's my view that as a matter of effective risk management within the clinic, it is appropriate for veterinary clinics throughout Canada to adopt a vaccination policy, and that you are permitted to adopt a policy of mandatory vaccination for employees, but with the caveat that you need to be mindful that reasonable accommodations need to be made for those employees who, either through medical, religious, or other cultural conditions, cannot be vaccinated. So the general policy is that you can adopt a policy of mandatory vaccinations, but such a policy, I think, needs to come about after some thoughtful consideration about what makes appropriate good sense in your own clinic. As you know, there's many public venues that have introduced the notion of mandatory vaccination. Restaurants, pubs, concert halls, sports stadia and arenas. And most provinces have implemented legislatively rules that you must show proof of vaccination in order to enter those types of public venues. I suspect that many of you will be aware that there's some fairly significant public debate at present about the rationale of distinguishing one type of public venue from another type of public venue. But those types of policies for mandatory vaccination are in place. That being said, employees of private businesses, such as veterinary clinics, are not required to provide proof of vaccination for access to the workplace, unless, of course, such a policy exists. And as I've already telegraphed, I think the notion of adopting a policy that is appropriate for your clinic is prudent and a good source and example of effective risk management. As you know, and the launch point of the analysis for that recommendation is that in every jurisdiction in Canada, employers are required under occupational health and safety legislation to provide for a safe workplace. Employers are mandated to ensure that employees can work safely within the confines of the business environment. At this stage, though, federal, provincial, regional public health authorities, administrative bodies, human rights commissions. None of them have really offered us a clear picture of guidance for those on that particular issue of providing a safe workplace. As you will be aware, the federal government recently mandated mandatory vaccinations for all federal employees, but the rest is really a patchwork of policies and conventions that will continue to evolve as we continue through the pandemic. I can tell you that the Ontario Human Rights Commission has taken the position, and I'm quoting, mandating and requiring proof of vaccination to protect people at work or when receiving services is generally permissible under the Ontario Human Rights Code, as long as protections are put in place to make sure people who are unable to be vaccinated for code-related reasons are reasonably accommodated. That position is simply a restatement of the general rule across Canada that in providing a safe workplace, an employer cannot discriminate on various prohibited grounds and must provide accommodations to employees, in this case, to employees, if you choose to adopt a mandatory vaccination policy, to employees who can't reasonably be expected to be vaccinated. As such, it strikes me that it's reasonable for an employer, such as the owner of a veterinary clinic, to impose restrictions for mandatory vaccination and require non-vaccinated employees on a case-by-case subjective basis to provide for less intrusive alternatives to vaccination for the purpose of maintaining workplace safety. But there are risks associated with mandatory vaccination policies, and I'm not advocating. I have my own personal view about mandatory vaccination, and I'll be transparent and let you know that I am absolutely in favor of mandatory vaccination as an editorial note, but I leave it to your own clinic management to determine whether or not you want to adopt such a policy for your own hospital. But in doing so, there are some risks associated in law. There are risks related to human rights legislation and notably discrimination claims. There is potential risk in terms of privacy considerations. There could be allegations of constructive dismissal if in fact the alternative to a mandatory vaccination policy is terminating the terminating the employment relationship of a non-vaccinated employee. And particularly in the province of Quebec, which has its own provincial Charter of Rights and Freedoms. One of the fundamental rights in the province of Quebec is the right to refuse medical care. And so in the province of Quebec, there may be constitutional exposure for a mandatory vaccination policy. Anecdotally, just my own observation, I think that we have witnessed a shift, a bit of a shift at least, in the thinking about mandatory vaccination. Many who were unvaccinated have moved towards vaccination as a result of their desire to maintain certain lifestyle choices, like access to a Raptors game, access to your favorite restaurant, those types of things. But we need to be aware, and you need to be aware, of the risks associated with adopting such a policy. In my view, all of these risks are acceptable. I think that they are imminently manageable, and you just need to adopt policies that will offer you the most protection from legal exposure. From a human rights perspective, you will be aware that human rights codes throughout Canada prohibit discrimination on a number of prohibited grounds. The relevant ones, as it comes to the notion of COVID-19 vaccinations, would be physical conditions, mental conditions, religion, ethnic origin, cultural prohibitions. And so in the event that an employee refuses vaccination on one of these grounds, you need to be able to accommodate that type of legitimate ground. So if an employee can present you with, in the case of a medical condition, an opinion from his or her physician that vaccination would be inappropriate, then I think that you are still required, in fact, I know you are still required under human rights laws, to reasonably accommodate. The test for reasonable accommodation is a very high one. That is, an employer needs to accommodate an employee who can't comply with the policy to the level of undue hardship, which is a very high bar. And that may involve working from home for potentially management positions within the hospital. The hospital manager may be able to effectively work from home. As you know, in a veterinary clinic, remote working doesn't really work that well for frontline staff. But maybe it means moving an employee to a less front-facing position, not interacting with the public where there may be exposure, maybe moving away and being socially distanced within the clinic from other employees, and adopting screening methodologies, which I'm going to comment upon later. Privacy rules, once again, vary from province to province. Generally speaking, an employer can only collect personal information when it has a legitimate purpose for doing so, and the information has to be limited for that particular purpose. In the context of our discussion today, that legitimate purpose would obviously be workplace safety. And so I think that certainly in terms of privacy law, there is a legitimate reason for obtaining personal information. There's very little case law on this in Ontario. Vaccination status has been determined to not be personal information. And as a result can be obtained by the employer. But the reasons for not being vaccinated would be viewed as personal information. And as a result, I think the general consensus is that if an employee refuses to comment on his or her vaccination status, then the employer can assume that that person is not vaccinated and then work with that particular employee in terms of accommodating if there is a mandatory vaccination policy within the clinic. I think it's important that you adopt a privacy policy within a vaccination policy that sets out how the information is going to be collected, the purpose of the collection of that information, that is workplace safety, who's going to have access to that information, how long that information is going to be retained, and anyone who has access to that information, I think appropriately should be on a need-to-know basis for that person to effectively fulfill his or her job function within the clinic. I want to now then turn to the development and implementation of a vaccination policy. And whether that is a mandatory vaccination policy or some other vaccination policy, I think it's prudent for a clinic to adopt a policy. I think as a matter of risk management, it's important that all employees know what the expectations are, know what the rules are, and that there is a clear understanding of how the rules are going to be enforced moving forward. And so I think the policy that needs to be adopted probably deals with 8 different considerations, which would then make up the policy statement. The first is to set out the purpose of the policy. Why is the hospital implementing this policy? And I think that the obvious answer to that, as I mentioned earlier, is for workplace safety. We want to ensure that all employees and clients who are visiting at the clinic are protected, that they're in a safe place, and in accordance with public health authorities in advice that is provided by public health authorities in your particular jurisdiction. The second element you want to do, or you want to set out, is the scope of the policy. Who does it apply to? Does it apply to all employees? Does it apply to all contractors? Does it apply to clients? The third then, and maybe arguably the most important part, is what is the policy? Are you adopting a policy of mandatory vaccination? Are there grace periods that are going to be implemented? You can see that that's happening in some sectors. We look at the legislative assemblies and we know that leaders of political parties are seeking mandatory vaccination for all MPs and MLAs and are providing a grace period. And then there's a lot of political discussion that is advanced when those policies are not enforced. And are there alternatives to the policies? You know, some type of rapid testing, ongoing screening, how often? The fourth part of the policy is to set out clearly the consequences for non-compliance. Does this involve a change in your work assignment? Does it involve an unpaid leave of absence? Does it involve altering the benefits that you may or may not be entitled to as an employee? Are you going to introduce remote working for some employees where it seems appropriate? Will there be enhanced testing for those who can't comply? I think the general feeling in the legal community at present is that termination of employment is likely to be viewed as a brutal consequence for a non-compliance with the mandatory vaccination policy and could give rise to claims for constructive dismissal that I'm going to comment upon. Of course, that is subject to change as more and more cases find their way through the courts. And it is within the realm of speculation that the judiciary could adopt a view that says that in order to ensure that the employer's obligation to provide a safe workplace could give rise to inappropriate circumstances for the termination of employment such that it does not constitute wrongful dismissal, that could happen. We're just not there yet. And I don't think I could in good conscience recommend that termination of employment be set out as one of the consequences for non-compliance, particularly when there are many alternatives that you can do to implement that you can accommodate an employee. The fifth part of the policy is to set out the duration of the policy. How long does it last for? Is it temporary? Is it going to end on a specific date? Are you going to attempt to tie that to the recommendations of public health authorities? The sixth, and I've referenced this before, is to ensure that your employees are familiar with the privacy policy and to deal with those elements that I referred to earlier in terms of how the information is collected, how it will be used, who will have access to it, how it will be stored, and the like. The seventh part of the policy is to deal specifically with accommodation and what types of accommodations the employer is prepared to make to the level of undue hardship in order to have this policy effectively implemented among those who legitimately cannot be vaccinated. The eighth and final part of the policy then is to deal with amendments to the policy, because as I prefaced our entire discussion today, this is rapidly changing. And as we've seen, a lot of the rules are being implemented on a sector by sector basis. I'm not familiar with a general consensus among veterinary hospitals, veterinary hospital owners, or provincial authorities. But that may be coming in the future. And as a result, I think that it is prudent that the clinic be nimble enough to be able to react to new policies as they are presented. As I mentioned, one of the risks of implementing such a policy is the notion of constructive dismissal. Constructive dismissal is a legal notion where an employee asserts that his or her employment has been wrongfully terminated as a result of an employer creating a hostile environment or a fundamental change in the terms of the employment arrangement, so as to create a workplace environment that they find intolerable and can't continue to work. I think we need to have that notion in our minds as we develop these policies. That being said, I think that the social reaction to mandatory vaccination policies is gaining some momentum. There may be more acceptance of it, such that constructive dismissal may not become a significant threat as we move forward. And for those of you joining us from La Belle Provence, be mindful of the Quebec Charter of Fundamental Rights and Freedoms in terms of the right to refuse medical treatment, and give some thought to whether or not that is an absolute right or one that is, as is the Federal Charter of Rights and Freedoms, reasonably demonstrable in a democratic society as being something that could be impinged. The third aspect, so we've talked about where we are in terms of mandatory vaccinations. We've talked about the content of a vaccination policy within the clinic. The third and final element I wanted to deal with is to deal briefly with screening protocols. Again, this is an emerging area on a sector by sector basis. I have not in my research and preparation for this town hall meeting found any trends or conventions that are emerging. But what we have seen is that in some sectors, mandatory vaccination and screening is a requirement. Retirement homes, long-term care homes, some construction and building enterprises that require, twice weekly rapid antigen testing, food processing plants. All of those have been determined in the law to be appropriate in terms of requiring ongoing screening. I think what is also emerging is that if screening is going to be suggested as an accommodation to a mandatory vaccination policy, I think at present, my advice would be that employers should be assuming those costs of testing. I'm sure Dr. Weiss may have some commentary on the access to testing kits, the cost associated with those testing kits. I'm only aware through the media of the cost associated with that. But from a legal perspective, I think that the employer should assume those costs. And because my thinking on that is that imposing screening testing and requiring employees to assume the cost of that testing is likely, in my view, in my legal opinion, to be viewed as a substantial modification to the working relationship, such that that notion of constructive dismissal that I spoke on earlier may come into play. And so at least for the moment, I think employers assuming the cost of screening tests is likely the more prudent route to proceed. Dr. Weiss, those are my substantive comments at the moment. I do have some commentary that may work its way through some of the questions in terms of remote working and things like that. I don't think we need to dwell on it because, as you know, remote working in the context of a veterinary clinic isn't particularly practical. And so as opposed to taking up a lot of time on this town hall session with remote working, unless we receive a question, I'm going to turn this back to you, Scott, and follow your lead.
Great, thanks a lot, Doug. That was great. We've got some questions in the chat. I don't know if you want me to ask you them or if you want to take a look at them. I just had maybe a couple of points to comment on what you said, if you have any added things from what I'm saying here. So the medical exemption side is a really interesting side. There's a lot of really dodgy medical exemption information out there. The vast majority of people who claim a medical exemption don't actually have one. And I don't know other provinces, so my apologies here, but for Ontario, the bar is set very high for a medical exemption. And if you want to know what they are, again, for Ontario, I can put this in the chat, the link. But basically, there are two medical contraindications to vaccination. One is an allergy, a severe allergy, to one of the components of the vaccine. So with the mRNA vaccines, that's very rare. And the exemption is only valid according to the province if that is determined and documented by an allergist or an immunologist, and the immunologist or allergist has said that vaccination can't be done. The other medical contraindication is myocarditis. And again, that's only substantiated if an expert, which they don't define, but would be cardiologist plus or minus infectious disease physician probably, say that vaccination cannot be done. This isn't just some random physician saying, do you want to be vaccinated? No, okay, I'm going to sign off on this, because there are a lot of people who are pressuring their physicians to get these. And provincially, when you look at the requirements for a medical exemption, there has to be the explanation of why on that. The province's requirement is it's got to have the nurse's name or nurse practitioner, physician's name, all the other stuff, and it's got to say if medical exemption, it has to say why. So just so you understand, if someone's coming at you with a medical exemption request, and I know, various places that are dealing with this, the ones that are taking this seriously have denied the vast majority of medical exemptions. It's estimated that the medical exemption numbers are between 1 in 100,000 and 1 in 500,000 that are truly a medical contraindication to vaccination. So if you have 20% of your staff that are medically contraindicated, you got some weird gene pool in that area, or you've got a lot of people with questionable exemptions. So I don't know, Doug, if you want to jump in on this.
Yeah, Scott, I echo your comments on that. In order to raise a claim for discrimination based on medical grounds, there needs to be a legitimate medical reason underlying the request for that exemption. And the case law is already spoken to this. It requires the type of evidence as a matter of law that Dr. Weiss has commented upon, and various tribunals have determined that a general fear of coming down with COVID-19 is not sufficient medical grounds. There needs to be some contraindication, as Scott has mentioned.
And maybe a comment on testing, because that gets talked about as the alternative. Testing is not a control measure. Testing is not a replacement for vaccination. Testing is a surveillance method. And surveillance methods can help reduce the risk, but testing itself is not a control tool. So if you wanted to think about using rapid antigen testing, that's usually as a supplement to vaccination, ideally. And that's not, that's what's being used as the default in a lot of areas. If you don't get vaccinated, you bring in rapid antigen testing. But I think you're finding a lot more, especially over the last couple of months, places that had that exemption have withdrawn that. So you can't use rapid testing now as a replacement for vaccination. So you're either vaccinated or you're not. That's the end of it. I don't care if you show me a rapid test. And part of that comes down to just the predictive value of the test. And part of it comes down to, I think, trying to drive better vaccination rates, because the vaccine passport, the vaccine requirements, that's what's driven a lot of extra vaccination. So antigen testing still can be useful. It still has a role, but it gets misused a lot. So rapid antigen testing, where it gets misused, is when you're trying to not do other things and you're trying to rely on testing. Testing tells you what your status is right now with a relatively insensitive method. Testing that's also used to clear someone to participate when they're symptomatic is absolutely what we don't want to do. And that's the big concern. It's okay, well, I'm not feeling very well, so I'm gonna take a rapid antigen test. If I'm negative, I'm gonna go to work or go to wherever. And that's not what these tests are designed for. The negative predictive value of these tests is very, very good for asymptomatic people. The negative predictive value for these tests in symptomatic people is very bad. So it's not meant to clear people that are sick. So your kid has sniffles, you don't do this test, and if it's negative, send them off to school. What this is used for is if you want to bring it into the workplace, you say, okay, every Monday or every whatever, we're going to do rapid antigen testing on everyone. And we're going to say if anyone's positive, and then they go get a real test. Real testing, PCR test, a more sensitive test. So we're trying to identify, using surveillance to identify a problem, pull them from that population, as opposed to using it to say, yes, you're absolutely safe to come to work because you're not vaccinated or because you're sick. So hopefully that's clear. But if you're thinking about rapid antigen tests, it's figuring out how to use them. Again, jump in, Doug. Otherwise, I could start asking some questions from the chat.
Oh, listen, I've got the chats up, and
okay.
So I'll just start dealing with some of them, I guess. Dr. Lister has asked whether it's legal to ask a potential hire whether or not they are vaccinated. And Claudia, in my typical fashion, I can give you the typical lawyer's answer. It depends. From a privacy perspective, absolutely, you can ask whether they're vaccinated. I think that the privacy commissions have all determined that, as I mentioned in my comments, vaccination status is not personal information and thus subject to the privacy laws. That being said, if you determine that they are not vaccinated, you may not be able to ask why they're not vaccinated. And certainly you could not discriminate against them if the answer they gave was not satisfactory to you. If they claim that they're not vaccinated based on some religious impediment to doing so, it could arguably be a form of discrimination for which you would need to provide reasonable accommodations. So Claudia, I hope that deals with that particular question for you. Natalie Cummins, can employers implement mandatory testing for employees who are not vaccinated against COVID-19? And Natalie, the answer to that, as I mentioned, is yes, subject to being mindful of the need to provide accommodations for those who cannot be vaccinated. Dr. Lister is particularly curious today because she presents a second question. Are we legally or morally obligated to disclose the vaccine status to clients? Claudia, I'm not going to take the bait and provide anything relating to anyone's moral compass on whether or not. I think that's an interesting question. And if others want to chime in on that, I'm happy to participate as well. I'm not aware that you are legally obliged to disclose vaccine status to clients, but I think that, you know, exercising the appropriate public health recommendations for clients in the clinic is an appropriate thing to be doing. Scott, did you have any comment on that?
No, I think that sounds good. If you want,
I
thought you a couple other questions.
I thought you would take the bait on the
more. If I take the bait, yeah, I think there's a moral responsibility there. I think we have the infectious disease knowledge, and we need to protect our staff, and our families, and our clients. So I always take a little bit more aggressive line of these than Doug, because I don't know much about the law, so I can be a little bit more forceful on that. But I think we have to consider our role, and the fact that veterinarians are looked to as we should be looked to as, you know, these One Health practitioners that are protecting the public and protecting our staff, protecting our clients. So I like to hold ourselves to a higher bar there. And I'd like to just do all that we can do, pushing that, you know, we're not going to go above that legal limit. I think we should try to push that limit as much as we can if we think it's right.
Sure.
So yeah, you baited me into it.
I don't disagree with that at all. Colleen Pratt asks, how would you suggest accommodating a receptionist with their high exposure to the public? Two comments. The first is, I think receptionists in veterinary clinics are often not recognized for the very important role they play in the clinic. I mean, in many respects, they are the face of the clinic. Your clients will know the receptionist on a more personal level than some of the veterinary staff do. So I think offering accommodations to a receptionist in the appropriate circumstances is appropriate, obviously. How to do that, I suppose, is a matter of hospital practice management that I don't profess to be an expert on. I suppose that the things that come to mind would be, enclosing that person within a barrier set up with plexiglass and the like, as you see in many restaurants and retail stores. I suppose, thinking at a higher technology level, doing that by video camera or by interactive virtual might be another way of doing it. The receptionist, he or she could be in another area of the clinic with a screen at the reception desk. Obviously, you lose some of the luster of that personal interaction, but that is a way it could be accommodated. There may be others who are attending the town hall today that have much better ideas about how to accommodate that front-facing employee, but I think that one doesn't need to think too hard of actually several ways that that person can be accommodated to continue in that role.
Can I jump into that for a sec, Zach?
Sure.
Yeah, the plexiglass thing is interesting because I talked about plexiglass a few times and I was kind of waffly on it, saying it's probably useful in some situations, but it depends on ventilation. And I think that we're even moving more towards yeah, it might be useful in like some situations, but it really depends on ventilation. Because the problem with plexiglass is, like, are you creating an infection chamber in that person's area? So you're cutting down some of the aerosols, you're not cutting down the truer airborne components. But so if you make this fishbowl in your reception area, and you don't have much movement with the clients, you're probably protecting the clients, but you might be substantially increasing the risk to anyone that goes in that area, meaning your staff, or if you have another receptionist in there, because what you're doing is disrupting the normal dispersion of the virus that she breathes out if she's infected. So I think we're really backing off on plexiglass being an overly useful tool, and you have to think about the context and what it's preventing and how it's disrupting airflow. And something you can do, though, is a HEPA filter. Like, if you got someone that, if you're gonna let them be in there unvaccinated in their public facing site, which has got a lot of risk factors on there, that's when you really need to think about optimal ventilation. And you really should be thinking about, a big ass HEPA filter in that area so that anything that's being liberated by that person is moving through properly and being HEPA filtered out. And HEPA filters are easy to get these days. They're cheap and they're highly effective. Plus ways to remove them physically, as Doug was saying. But don't rely on plexiglass as being your only control tool, because it could actually make some things worse in some clinics.
That's good clarification, Scott. Gerald Hauer asked the question, scope, can you have different approaches to different groups? Can you require staff to be vaccinated but not clients? From a legal perspective, you certainly have some level of control over your staff in terms of mandatory vaccination. I think you have less control over your clients, except if you introduce a policy of having to prove vaccination status, as they do in other venues that we've talked about. Will that become the norm? I don't believe it's the norm at present, but that may become the norm. And as society, is facing the notion of vaccination passports and proof of vaccination status to access many venues, that too may become the norm for private facilities such as the clinic and retail stores. Scott, any comment from you on
that? No. Sorry, I got a phone ringing in the background. I'm trying to get someone to pick up. No, I think that's good. Did you want to keep going questions, or do you want me to actually, there was one there about immunity. Maybe I'll jump on that one while you're looking at the other one. So is proof of natural immunity a replacement for proof for vaccination? And the answer for that is no, for a couple of reasons. I think someone else I saw later comment about study that's shown natural immunity to be inferior to vaccine immunity. Yes, there are a few studies that have shown that. There's one recently out of Kentucky that showed people that had previous infection were twice as likely to get COVID versus people that were vaccinated. We don't have a good test for natural immunity. You look for antibodies, but that only tells us a little bit, but it is fairly clear that these vaccines are exceptionally good and they probably are better. Now, long-lasting immunity, is one better than the other? We don't know, but there are enough people that got recurrent infections The other thing is if we see shifts in variants, we're potentially and probably going to see more impact on natural immunity than vaccine immunity. The vaccines have done a very good job of maintaining their protection across our variants of concern, where the natural immunity has not. Best identified, I guess, in Brazil when they saw 2 waves go through Manaus with a new variant and massive reinfection rates with something that the vaccine would have covered. So vaccination is superior. That's the short answer to that.
Scott, in the same vein, Paula Bedford has asked a question that is more within your expertise, I think, in terms of clinic sick policy. Should any even mild symptoms necessitate they stay home? How do we staff heading into flu season with a policy like this?
Yeah, that's tough. Flu vaccines are available now in Ontario, so that's one of the big things. It's a challenge, right? Because ideally we're really aggressive when we keep people home. And I think this comes into the context of where we are in the pandemic, where you are in your clinic in terms of susceptibility, how good your clinic is in terms of infection control. So the more unvaccinated people you have in the clinic, the poorer the ventilation, the more mixing, the more people you're allowing to come into the clinic, the more you're cramming into exam rooms, the greater the risk versus a place where everyone's vaccinated and you're still doing a lot of curbside. You have great ventilation and you're doing minimal contact appointments through doing a lot of stuff in the back room. It gives you that flexibility. It's that Swiss cheese approach that I keep ranting about, right? We've got all these different layers. And, sick policies like that are one of these layers. They're a really important one. But someone's got, allergy-like signs. Enough clinics have been burned with people that thought they had allergies who got into the clinic and had COVID and shut the clinic down. So we have to be careful with these mild signs. So there isn't a straightforward answer to that, but I think you have to put it in the context of your clinic. And ideally, again, I like to be as aggressive as possible within reason, right? You don't want to shut down your clinic operations, but you also don't want an outbreak of COVID, and you don't want to be you don't want public health contacting clients and so-and-so there's an exposure at your clinic. That's not good at various levels, including a PR level. So I think having a policy, and this is where the provincial screening tools that most provinces have are useful. And, they don't tend to flag the really mild, the rhinitis. So runny nose doesn't get you in there, even though it could be COVID, but it's low likelihood. But once you've got to the point you've got like flu-like disease, that could easily be COVID, and it could easily be a breakthrough infection if that's the person that's vaccinated. So I think at this point in the pandemic, while we're still are in a wave and we're heading down and we're still trying to optimize vaccination and we're still trying to optimize clinic operations, and we're starting to increase things that are done in the clinic. So we're ramping up a couple risk factors at the same time. And I think we don't want to be bringing potentially sick people in while we're doing all these changes. But you need to think of that in the context of the big picture.
Scott, your comment sort of sparked a thought I had too. And, we can talk about the legal exposure and the risk associated with not providing a safe workplace or transmission within the clinic, giving rise to potential claims against the clinic. But I think we also need to be mindful of the reputational risk to the clinic. Your comment, Scott, about having to close down. I don't know how you quantify the negative press that comes from that type of closure in the pandemic. So hence, having the policy in place, implementing it and enforcing it makes good sense. Carly Predecessor, I hope I'm saying that right, Carly, asks, do we have to accommodate employees that don't want to and don't have a reason? The answer is no. Accommodation comes with a request for accommodation, and presumably that request intuitively it comes from somebody who is prepared to accept the accommodation. And so if you have offered a reasonable alternative to mandatory vaccination, and they simply don't want to accept the accommodation, and they don't have a good reason for not accepting the accommodation, let alone a mandatory vaccination policy, then no, you have done what you can.
See, there's a question that just came into, I think it just came into me. It looks like, why do public health authorities not provide the public with details about who is ending up in hospital or ICU, unvaccinated versus people with 1 dose versus people that are fully vaccinated? And this varies by province and by reporting. In Ontario, this is now reported typically in the daily reports. It's the vaccinated versus the not vaccinated. And it's binary. It's either you're fully vaccinated or you're not. So that could include partially vaccinated individuals. I'm not sure about other provinces. I'll put something in the chat here too. So in Ontario, we have our provincial science table where about every 2 weeks we release some data. And in that link, there is a chart that shows vaccination in terms of vaccination versus unvaccinated in terms of cases, people in hospital, and people in ICU. And basically, it's really low numbers of people in ICU, 61 times plus ICU rate in people that have not been vaccinated. So there are a few breakthrough infections that can make people very sick. You know, vaccines are good at preventing infection. They're very good at preventing severe infection, and they're exceptionally good at preventing ICU stay and death. So there are some data available, and I'm not sure about all provinces. Ontario's there.
Dr. Quanis, there's a question in the chat vis-a-vis CVMA's position. Is CVMA prepared to draft a policy recommending clinics put a mandatory vaccine policy in place? Is that something that you could speak to, Dr. Quanis?
Well, that's an interesting question, and I would refer a little bit, I think, to what you were talking about earlier, Doug, and that is that there's such a wide range of jurisdictional differences that it would be pretty hard for us to make a national recommendation at this stage. And I would hope that maybe further on down the road as things get hammered out, maybe we can, but I would think that it would be not something that would be nationally applicable at this stage. Would you agree with me on that or not?
Oh, it would be difficult. Not only do we see it vary from province to province, but sometimes we have these micro communities of region to region. And that, I think, Scott, is merely reflective of this virus. It's affecting different regions, different ways, with different rates of transmission and the like. We're all just sort of, learning as we go, I think.
See, there was a question there about best reference to share with support staff to override fear of vaccination from the vast amount of information that's out there. Is there a good reference for that? That's tough. I can tell you lots of places not to look at. But the ones, because the problem is you can send people to CDC, WHO, and Public Health Agency Canada, and those people are often a little bit wary of government sites already if they've been sensitized to the misinformation. Twitter actually has some really good independent people that have taken apart some of the things like ivermectin, some really good synopses of why the ivermectin data are fraudulent, a lot of it. So there are some good sources there, and these tend to be independent science groups as well as some science reporters. And I'm happy to pass on some of that. So I think that's where some of the debunking stuff, if you're looking for debunking, often Twitter is a good place to find it. Now you have to be careful who you're looking at, obviously, because Twitter, which is a bit crazy, but there are some really good things in there. When it comes to independent sites, obviously WHO, CDC, those sites have good high-level information. So it depends on the person. If the person just wants to know, then sending them to CDC, Public Health Agency Canada, those are great because they've got reputable, good quality information. If these people are a little bit, well, I don't really trust the government, I'm not sure what's going on here, then some of these online sites that will drill down and explain why all this stuff, like why this is misinformation. And there's a lot of it out there, as you know. And some people that come through with academic credentials that are feeding a lot of this. You can't just look at their title. It's a challenge. It's one of our big issues, and it's costing lives because people are hesitant because of the misinformation.
Wow. For Jordan DeWalt, just a point of clarification. My comment with respect to employees paying for screening was in the context of an accommodation. If someone will not adhere to a mandatory vaccination policy because of some medical reason, for instance, I'm suggesting that one of the alternatives would be regular screening with the results determinative of whether or not they can attend at the workplace or not. But that would be done in the context of an accommodation. I was not advocating introducing screening for all employees at present.
Keep tossing questions in if you have them too. I'm not sure if you got through them all. One thing I was maybe going to bring up briefly was molnupiravir, Merck's new drug. There are a lot of questions about that, whether that's a replacement for vaccination. And the short answer is no, for lots of reasons. So this is an antiviral drug, a repurposed antiviral drug that might be effective. And I think, we were all really excited 2 weeks ago when it came out, and we're all getting a little bit, I'm not so sure right now. The data just haven't come out. Merck hasn't released much of it. And they've asked for emergency authorization in the US based on one study. And the key is figuring out if that study really applies to the populations where we would use it, which is, the Canadian hospitalized population in the Canadian healthcare system. And we don't really know that right now. It certainly does have potential. It probably has a lot more potential than remdesivir, which has been a pretty craptastic drug for SARS-CoV-2. Now, will this be the silver bullet? No, for a few reasons. One, it's meant to reduce severity of disease. It's not something you're going to pop every day. And there's a cost issue. Right now in the US, where they've contracted out over $1 billion in advance, they're getting it for about $1,000 a dose. We're going to pay probably substantially more and have substantially less of it here. So it's not, you're going to be able to walk into your pharmacy and say, I got 20 bucks, give me a dose of course, molnupiravir. It's going to be used in high risk situations. So where it's going to be used is you've got a person with severe early disease. You've got a person who can't be vaccinated or is at high risk for poor vaccine response. You've got a person on chemo and they've been vaccinated and we know they aren't going to respond very well and they've been exposed or they've got early COVID, they should get this drug. It's not meant for your 30-year-old who just doesn't want to get vaccinated because the cost benefit maybe isn't there. We don't know about the efficacy and it's not going to prevent transmission. Like vaccines are there to help prevent you from getting sick, but also to stop this pandemic. Antiviral treatments, early antiviral treatments are not a control tool. They're a disease prevention amelioration tool. So, this could potentially be very useful for high risk populations. Like we're hoping we're going to have access to it. We're hoping we can prevent deaths in these compromised individuals that aren't able to respond very well and that are high risk for serious disease. But it's not something we can say, okay, now we've got this. It's like penicillin came in and we're able to control Staph aureus infections, right? You're not going to have that same degree of widespread impact on the pandemic. It's a clinical aid. So just make sure we aren't assuming that we don't need to be focusing on vaccination and other control measures because we have an antiviral, because odds are if you get sick, you're not going to get access to this, at least right now.
Dr. Kimann, I think we've probably dealt with most of the questions in the chat room, and if there's others, we can, through CVMA, they can send those to us directly. So I will turn it back to you to adjourn.
I see one more, and this one just came into me, I guess, to a question about COVID vax for 5 to 11-year-old kids. I think we'll have that very soon. We were hoping early November for licensing. We haven't really heard anything more. I haven't. Science Table, as far as I know, hasn't heard anything more since then. It's going to be rolled out probably like the original vaccine. There may be prioritization of the high-risk populations. It depends on how much we get. So this isn't using the same vaccine. This is using a lower dose version that Pfizer's making. So it will depend if we get 5 million doses versus we get 2,000 doses. If we get small numbers rolling in, they'll get prioritized to the high-risk kids, just like we did with the vaccination of adults. If we get a crap load of it, then the mass vaccine clinic, and ideally the in-school vaccine clinic, will be the way to go. So we're still hoping that this might be able to roll out in November. I don't really know. For it to have an impact on disease, you're probably looking at a good 2 months post widespread implementation of vaccination by the time you get population coverage enough. So, we're kind of holding away in that lower third wave in a couple of provinces, fourth wave in a couple of provinces. We have a couple of provinces that are a big mess. This isn't something that if we start in a couple of weeks, we're going to slam the door on the wave. What it's going to do is help tamp down in that population and prevent a fifth wave from coming in. So this is going to be a key thing for us because we have a lot of 5 to 11-year-olds, and the studies are being done on the 6-month up too. So ultimately, we should have the ability to vaccinate, almost all the population. But with Delta, we need to get those groups covered to be able to control that. So I think if you have 5 to 11-year-old kids, it certainly is on the short-term horizon, and hopefully we'll get a lot of them done before the end of this calendar year.
All right, then, thank you very much. Tried to share this screen here because we have a thank you slide, but I guess you just have to watch me. Thank you very much, Dr. Weiss and Mr. Jack, for the information you provided and for your insight and advice. And thank you for each attendee for participating today in the 16th CVMA Town Hall on navigating through COVID. I hope that there won't be a whole lot more of these needed, but it's obviously an ever-changing scenario, and so it will continue on an as-needed basis. I know many of us on the call today are tasked with making decisions that affect others and on behalf of others, and the information we're given today will help with that. So although the responsibility of doing so is not easily or lightly done, we ask that in this time of pandemic-related societal dis-ease, well, we wish you all the best and ask you in this time to be brave enough to be kind at all times. And thanks again for everybody for participating. And on behalf of CVMA, good day and goodbye.
Thank you.
Thanks, everyone. Thanks, Doug. That was great.
Thank you. Bye-bye.
Yeah, thanks. Bye-bye.